So, good morning, everyone, and wish you a happy Sunday morning. Thank you for being with us on a Sunday morning. So, this is the case discussion 14th in the series, and we have a very enthusiastic presenter with us here today. So, I'll quickly introduce Hannah so we can go on to her screen share, and she has a lot to tell us today. So, Hannah holds a degree of MSLP and she's presently a partner and rehab manager at GrowCare. She has been a clinical audiologist and speech therapist at the Saifi Hospital in Mumbai for 11 years now. She has also been a consultant ASLP at Param Speech and Hearing Clinic and Kankutara Medical Diagnostic Center. I'm sorry if I spelled that wrong. She is presently a rehab in the position of a rehab manager, and her role at GrowCare includes charting out customized rehab program within flexible therapy hours, taking into account social, physical, and mental well-being of the patients, making more treatment options available with the motto of ACE, that is aiming improving quality of life, consistency in endeavors, and excel at providing health care at home. Her skills include that in aphasia therapy, dysphagia, fluency, healthcare management, neuromuscular electrical stimulation, professional voice, and public health. So, welcome, Hannah. Thank you for doing this with us.
Hi,
You have a
good
very
morning.
comprehensive case planned.
I know. Thank you so much for this opportunity. Had it not been for you, I would have not pushed myself into this. So first and foremost, thank you for this opportunity. And it's my first time doing this, so please bear with me for my technical glitches if there are any. I will try to keep it as smooth as I can.
Thank you. Thank you for coming on. Thank you for doing this on a Sunday. Please go ahead, share your screen. Please start.
So good morning, everyone. I'm Hanaa Mansoor. I'm rehab manager and partner at GrowCare. And today I'm going to be talking about role of speech and swallowing therapy in rehabilitation. Now, what a speech therapy does, all of us know pretty well, but I'm just going to touch base. We do assessment, diagnosis, treatment, intervention, education, support, outcome measurement, and research. Now, the last four are something which I think all of us should focus a little more on because that helps us personally to go as professionals. Now, by playing these critical roles, speech and swallowing therapists help the patients with neurological disorders or injuries to regain communication and swallowing abilities, improving their overall quality of life. Now, today I'm going to be talking about a case which is 68-year-old gentleman, Mr. Emin. You may think that I'm touching base on a lot of medical history, but that is important for you to understand because these events will show the prognosis. These events are going to tell you what treatment plan you should make. You cannot be stuck up on one treatment approach. You have to shift according to the patient condition. So let's jump into the medical history. Mr. Emin, he's 68 years old. The medical diagnosis is right thalamocapsular and corona radiata bleed with interventricular extension with midline shift. He's a known case of diabetes mellitus, hypertension, ischemic heart diseases, vitamin D3 and vitamin B12 deficiency. I saw him a month after his ICU stay. Just to touch on this past history of the ischemic heart diseases. This was back in 2022. I will come back to this when we are through the sites, but just keep in mind that he has a block, he has stenosis, and he has three multiple blocks. Now, patient's history, brief history on hospital stay is that he was on a ventilator. There was an X-ray done which showed pneumonitis. Then, as his sensorium improved, he was planned for extubation. A laryngoscopy was done prior to FRECA. Tracheostomy was planned for 2nd August. So he was admitted on the 16th of August, on 16th of July, and then this is a course of treatment. Medical line of treatment which was necessary was done. There was a lot of sodium correction which had to be done. CT scan was repeated. It showed that there was a decrease in the sign of bleed. However, the patient was febrile, so the intensivist went for a medical line of intervention. Tracheostomy was done. They tried to give a CPAP trial, continuing the patient on TPs and PC mode weaning. Now, patient was mobilized to a neurochair. He was able to follow simple commands. At this point, the neurologist added some anti-epileptic drugs so that we do not have an event of epilepsy happening. Tracheal culture was done. Medication was started because he was febrile. He was having fever. Now, when the patient was able to tolerate the PPPs for more than 24 hours, he was shifted at home with necessary home care because he's been in the ICU for already 1 month. The family is concerned that further ICU stay. We don't know how long it's going to take, so we take him home. This is a point where we come in picture, where I come in picture. I am not only a part of his speech therapy program, I'm also his case coordinator, where I look on for his overall management at home. So a lot of things apart from speech therapists, like getting arrangements, things to be done, that if something is going wrong, the nurse raises alarm to me, I take it to the doctor. Why all this? Because the patient is primarily living alone with his wife, the kids are not home, so we need someone actively present to monitor these patients. Now, the GCS was 15, which was a good starting point once he was home. But suddenly at night, we had a drop in pressure, and there was absolutely no reason for a drop of pressure, but that happened. So the nurse was monitoring a fast. We got in touch with the neurologist. I forgot to mention that his nephew is a leading endocrinologist who also monitors the case. And we tried doing whatever positional changes, we tried doing BP charting, but it was still not stabilizing. So what we decided to do was that we start an IV antibiotic treatment at home. Now 15, so 12th August, we prepare to come home, and then the chain of events that happen, we do a chest x-ray. The next day, the patient pulls off his freca. We have to do a reinsertion of the freca at home. There was persisting hypotension and fever, so the antibiotics had to be escalated. Now, this is done by an intensivist. The intensivist asked for the growth on TT culture. There was nothing in blood. There was nothing on TT. Suddenly, after some days, the patient is complaining of pain in hip joint. Now, the patient was made to sit in a wheelchair. He was taking the initiative. He did have some purposeful movements. However, the next day, again, a step back. We have loose motions. We again start medication for the same. Now, 20th August, the patient was taken to the hospital because he had to have a follow-up with his neurologist, with his orthoped for the hip pain. And because I was there at the hospital too, I decided to do a patient swallowing evaluation. We said we'll do it subject to his position, his fatigue levels. If he's good to go, we'll take a shot. So he did his neurologist evaluation, he did his ortho consult, and then I saw him briefly. So what did I see? So swallowing evaluation was done. Patient was able to tolerate deflated cough. Gag reflex was partially present. Dry swallow was present. So if you give him a command, yes, he is able to do a dry swallow. Cough reflex was present but weak. Swallowing response was delayed. There was a frank oropharyngeal dysphagia for water. HD was seen at 20 seconds. So what we decided to do is that we're going to practice deflation trials at home after suctioning. So we've taught the nurse how to do a deflation trial at home. He's a seasoned nurse. We also try to practice swallowing with gauze, sterile water, green color, and drop of lime for taste. However, the patient was not ready for the lime, so we only went ahead with water and color. Now we did an X-ray for him, which revealed an incomplete fracture. The hip pain that he spoke of, there was an incomplete fracture. Maybe could be a past injury or something while shifting in the ICU. We don't know. So his mobilization was restricted for 3 weeks. Now this was a setback for us because in the posture-wise, we could not do much. So every event has an action to it. The BP was still not stable. He needed continuous monitoring. There was 3 kgs of weight loss from discharge. So we got a dietitian in picture, and we tried to change the diet. Now, again, this was a third episode where the patient pulled out the freca. He was just not comfortable with the tube. So then we decided that let's go ahead and get a peg insertion done for him. Also, the quality of nutrition, personally, I feel from a freca and peg, a peg is able to give you more better nutrition because we were seeing drastic weight loss, and especially the family being abroad and just having communication with the father on, through a video call. It was very demoralizing for them that, how can we help? How can we help? So we thought, let's go in for peg insertion, which will give them better quality of nutrition. So this is a series of sessions. There are multiple sessions done, but I've just put up a few of them. So we first started on 16th September. We gave him a deflation trial at home after all the episodes have settled in the background. He was able to tolerate the deflated cough. He was able to swallow his saliva. And after we did a water diet test, he was able to clear. There was no secretion, both in inflated and deflated calf. So we were happy that, we are doing a good start. We're making progress. Now on 21st, again, like a few days later, so we go in for suctioning, we go in for deflation of the calf. Everything is good. We give a water diet test. But at this point, there was no immediate traces in the tractor group, but there were some traces present. Now, again, the next day we observed, because we had some traces, we didn't want to delay. We said we'll observe it the next day itself. So we do a water dye test throughout the day, 2 hourly interval, and we stop at 8 p.m. And then we look out for any signs of the green dye in the TT the next day. So yes, we did have some microaspiration that was seen at night. Like you see, the green color tinge can be seen. Microaspiration was happening at night. Now he was able to cough out his secretion, but occasionally there was blood stains urine. So whenever you see blood stains urine and the family gets like, they think, is it okay? Is it right? What is happening? So we have to counsel them that yes, sometimes this does happen. What is important here is that he's able to cough out his secretion. Now, this was my first trial with semi-solids. I use this diagnostic tool by Asha because it's a very quick screener. It just helps me progress. So I used it as a ready reckoner. So we were able to feed him. He had good endurance during his meal. His mental state was he was alert. He's responsive. He's cooperative. Dentition was within normal limits. Lips were within normal limits, tongues were within normal limit. There was some protrusion, movements were slow, but movements are the range of movements is present. It's partially slow. He takes a little time to follow the command and do it. Now jaw, everything was within normal limits. Soft palate, there was no movement on the right side. Left side gag sensation was present. Phonation was absent. There was minimal phonation. Uh, Respiratory insufficient was present. We advised them to do a spirometry. We also had a physio along with the speech therapy sessions. They were focusing on spirometry. Now, food trials, the patient was sitting upright. There was no difficulty in participating in study. Saliva swallow was good at this point in time. So we went on with different consistencies. We had some water with the green dye. We had some for honey thick. We had some oats, which was prepared for the RT feed for the pudding thick. Then what I did was with the oats, I added some thickener to just see which consistency was better response. So honey thick and pudding thick, almost 100 ml was taken. After this, he asked for a banana. I've not mentioned this, but I clearly remember he asked for a banana because he loves banana. And we did give him some banana. And then he also asked for a sip of tea. It went on. For him, it was like, I'm able to eat. Boom. So, I want to have everything that I can. So we did give him some sips and there was no aspiration seen. Yeah, I've mentioned that banana is there. So that was good response. We were happy that, okay, we're able to at least start semi-solids. Come on, that's good achievement. Now, oral phase dysphagia, mild, moderate severity. Prognosis, we said was good at this point. Oral pharyngeal, not just oral. Now, recommendations. What were our recommendations? Swallowing treatment, definitely yes. Under supervision, no straw. After 5 to 6 multiple swallows was advised to him. So I'll read through it. Supervision was needed to be fed only by trained staff. Feed only when alert, reduce distraction. He needs verbal cues to do the strategies. Upright position, at least what strategies we're using chin tuck, and we are asking to do multiple swallows at this time. Okay, now with this in picture, the next week itself, there was a sudden shift. There was a sudden shift in the swallowing of saliva. Things began to differ a little. His swallowing of saliva became a little difficult. He was not able to swallow his saliva. There would be constant buildup of secretions, and he needed frequent suctioning. We were not making a head start. Obviously, the oral swallows were at a standstill. So we decided that let's focus on trying to wean him off the oxygen protocol. He was initially at 1 liter. Now, generally, it's sometimes in some patients, it's just like they're able to come off the concentrator of the oxygen support. But sometimes we have to be careful, and this was charted because we were trying to be very careful with him. We didn't want an unnecessary episode of a DSAT with him. So we started off with 1 liter per minute SpO2. The level was 1 liter of O2. The level was 99 to 100. We came down step by step. He was able to maintain at the end of this episode. Okay, he was on oxygen on room air. His SpO2 was a good 93, 95, which was permissible. And this was a good sufficient time. We were confident that, okay, we can consider, going without oxygen support. There was no DSAT, there was no change in heart rate, there was no change in BP on the cardiac monitor. Now suddenly, again, this was 13, and then we go on to 15th. We put him on the wheelchair for 30 minutes. And after that, we see there's a drop in SpO2. So we had to start some minimum respiratory support for him. And we decided that a half liter of O2 support is good to maintain good stats so that he's not under stress. So the patient needs minimal O2 support. Now we started sessions. This was a morning session. We had this problem that we faced was that the patient was sleeping through the day and being awake at night. So sessions were difficult to conduct because he was drowsy. We spoke to neurologist. He had introduced melatonin initially, 10 mg, and then he said we try to change the timing. So we were in this zone where the patient was not very oriented. We kept shuffling his session timing from 9 to 3, some days at 9, some days to 3, because there's sponging happening. There's so much, the peg dressing, everything was happening. We tried expecting to be alert and oriented, but it was not really happening the way we expected it to go. So this was one of the sessions where the patient was drowsy. It took him 15 to 20 minutes to get him to a really amenable level for therapy. He was off O2 for an entire session, which was very good for us. So then we went on with oromotor and swallowing exercises. Thermal stimulation was done. Suctioning was performed and speaking valve was fit. There was no episode of desaturation or fluctuations in heart rate. Coughing on saliva was observed, but so he needed prompts to swallow his saliva. We did a trial feed with 10 ml of black tea, deflated cough. There was delayed initiation of swallow. Patient was holding the bolus in mouth. There was frank aspiration and coughing was observed. So we've had a past episode where the patient was able to swallow so many consistencies, but suddenly one day, the next week, we see and he is not able to swallow. What went wrong? We don't know. What do we do next? So again, the follow-up, then we focus on spirometry. Incentive spirometry was done. A hereditary phase, he was unable to perform. Expiratory strength was fair. Voicing was present but weak and breathy. Better voice quality with digital manipulation. A tracing activity was done. Now we realize that it was over 2 months that we've not changed the TT because so much focus was given on stabilizing his BP and getting him to a neurological optimal level at home. But the TT was in the background. So we planned a visit to the hospital. Uh, there was setback a week to stabilize Holter. So at this point, there was a flutter. I think there was, it's written on top. At this point, there was a flutter in his heart rate, a sudden drop in his heart rate and BP both. And it went down to a really low level of 70s and 30s. And it was a major setback for us. We were like, is this some kind of cardiac episode? That's when the cardiac history comes back to mind. So we decided that okay, whatever program we've been doing so far, fine, but maybe now we have to slow down our deflation trial. So we give, the therapist has given oromotor exercises, the normal ones that we do, the stretching, the diagonal lip stretch, puffing and holding of air, and mouth protrusion of tongue, pushing the tongue against resistance. Okay, so we've given them a home program because we've trained the staff over there. The staff is a nursing staff. We've trained him. We've given them demos how to do, and we obviously drop by once a week. But active sessions were partially discontinued. We were waiting for things to settle again. Swallowing exercises were given when we were doing thermal stimulation with the steam spoon. We were giving him modified shakers, giving him masako. He was able to do this, but not always. He needs a lot of probing. And maybe if you ask him to do it 3 times, he'll do it once. So a lot of probing is needed repeatedly for him to achieve this. Speech exercises were given, perform suctioning and deflate, observe for 5 minutes. If the patient is able to manage his saliva and stats are stable, occlude the stoma using a micropore and check for DSAT. If the patient is able to tolerate, then the following to be done. Perform respiratory exercises using respirometer for inspiration as well as expiration 5 times. Practice voicing for speech as well as non-speech tasks. So we used to give him a timetable. There was a charting done for him where, in the morning we are having his dressing, then we are having his feeds, then we are having some form of exercises. So throughout the day, he's busy. Cognitive language tasks were used using set speech app, odd one out, categorical naming, sequential narration, basing, tracing tasks. You will realize through my presentation that I'm not focused a lot on language. Of course, it was there in the background. I use the set speech app by Tasneem and it's wonderful. So it makes things so easy and it's also very effective in saving time because you just go one after the other. So when you're already in a time crunch because you have to do your desaturation, you have to give a deflation trial, then you have to give you have to put an orator and see the patient is tolerating that. that. After all of that, then you move on to a trial feed, and then you have to save some time in language. So you have to cover all aspects of therapy. So in that, when you have an app handy in hand, it makes things very easy. Also, the carryover is much easy because then the caretaker at home, the daughter or the son from abroad, they can just continue the same task. So having some kind of app in hand for language stimulation, I think, is a win-win situation. Now, like I said, what does language consist on? 15 minutes of language stimulation, 15 minutes of swallow studying exercises, 15 minutes of oral try. Not necessary. So with the therapist, of course, we would try to achieve it together, but then throughout the course of the day, this was repeated by his daughters and by the caretaker. A neuropsychological evaluation was done. So we've taken the case in August. So much has happened. We've come to December, and despite so much of effort being put in by a physiotherapist, by a speech therapist, there are regular sessions happening, the patient was not really moving forward in time. His prognosis was quite guarded. So what do we do? Like, we know there's a cognitive limitation. We know he's 68 years of age. And we as the therapist, we know what happens when you have an underlying lesion. But for the family, it's very demotivating that is he going to come out of the stage? Is he ever going to improve? So the crux of the neuropsychological evaluation done was that patient needs continuous cognitive rehab, visual spatial rehab, emotional support, motivation support, regular follow-up and reassessment. It's a very common situation with all of us where we see the family members are like bolo, bolo, bolo. They just go on, and then in one of the sessions the daughter just broke down because then he was not responding. So we have to be really careful. It's not just our therapy, what we do, but also what is done afterwards. You can never squeeze out a response from a patient. It has to be relevant to him. At 68, most important, it has to be relevant to him. But what is important is that we motivate him, and it has to be continuous. It has to be consistent. Now, again, secretions were stopped, everything was good in picture, but suddenly we have again copious secretion coming in picture. So you see, you take one step forward, you take two steps forward, everything is fine. You are giving your rated trial, you're going for deflation curve for rated trial, you're working, you're trying to get him off the track, and then suddenly the secretions start again. It's not in your control, it's nothing you can do. So what do? You have to have a medicine line of treatment. You go on with the neb, you go on with the syrups, and you take the doctor in the picture, and then you see what to do. It's just a matter of wait and watch, but in the meanwhile you work on cognition. So a brief summary of where the patient is right now. He definitely has verbal responses. With probing, there needed non-verbal responses. There's pointing. Head nod is present, but if you ask him that, give me a verbal response, he'll give that to you. Voice is breathy, of course. Fluency is there, but again, it needs probing. Grammatical competencies, yes, he is able to speak in sentences. Like once, the caretaker was, they were just fooling around, and the caretaker was forcing him for a response, and he just spontaneously said, "Isko police ko de do." So he has proper structured sentences. It's all about his willpower. It's all about his mood. He wants to say it, he will say it. Paraphrases were not there. Information content was present. Auditory verbal recognition, yes, no questions. Auditory word recognition, sequential commands are all present. Naming, very interesting. Object naming is present. Word fluency, he's able to speak one or two words. Sentence completion is absent. That even after probing doesn't come in. Responsive speech tasks are present. He's able to read letters, numbers, and alphabets. Writing, so we at one point we have this where we got him a diary on each day, and we were like, just write your name, because we were a businessman. He's used to writing checks, making bills, so he was not able to write very fluently, but yes, he was trying to write. Vocal quality was breathy, vocal loudness was affected, resonance was compromised. uh, I would like to present some videos at this point. Okay, I'll come back to it later. So this is the role of a speech therapist in Crux. There was a lot more that we've done, and I could not, concise it any further. Imagine taking a patient from August till date, and the treatment is continuous, it's ongoing. We plan to get him off the track, but we've shown him to ENT, we've done fees multiple times, and he's not able to swallow his saliva. There are some good days and there are some bad days. We don't know when he will be able to swallow his saliva at a stretch and orator. So we give him a micropore trial, we give him an orator trial. Some days he's able to tolerate the orator trial, but some days he is not. So we as speech therapists, we just have to be consistent. We don't have to give up. We have to be doing the passive stimulation, the thermal stimulation, the exercises that we do, focus on language, keep motivating the family members, keep a regular follow-up. And I think very important is documentation. So once you document, you can say that it took this much span for him to achieve this retrospectively when you see. So I think documenting the work that you do is very important. With this in the picture, I move on to what I do as GrowCare. I would like to introduce GrowCare to you. It's a relatively new concept for rehab in, I would say, India, not just Mumbai. So welcome to GrowCare. GrowCare is an international company. It's based out of LA, and we have branches in India, in Mumbai, in Delhi, in Kolkata, and very soon we are also setting up a branch at Bangalore. So what we do is we bring medical value travel. So we bring expertise of doctors across the globe to patients. So it's a two-way process. It's not just taking the patient to the doctor, but if there's supposing like we had a consult for one of the patients in from Kolkata, we took her to LA for a cancer review. But in some case, we took a nephro to the patient. So it's a two-way exchange. So we are tied up with approximately pan India 200 hospitals. So if I could brag about it, we have Manipal, Apollo, Fortis, pan India. In Mumbai, we have SSO, Sefi, Wokhad, Just Lilavati, Kokila Bain. Then in Chennai, we have Mayot. In Delhi, we also have Artemis. We are also looking at tie-up with Max very soon. We are in discussion. So basically, we are covering pan-India level. The point of reaching out at pan-India level is that tomorrow, if I have a patient who says, I want to go to this particular hospital only, we should be able to facilitate the treatment that he wants. We should not, just because we are not associated with a hospital, we should not, no. So we are healthcare facilitators providing access to good treatment, especially for patients not just from India but also from Bangladesh, then from LA, from Canada, from Tanzania. There's a city called Mwanza. We also have partners over there. Of course, from Middle East, we have partners in Dubai Health City. Then from Singapore, from Malaysia, from I would say wherever the patient has access to our chat services, they're welcome to reach out to us. The second product we have is elderly management. Now, this is the need of the hour with an increase in the number of people, young adults going to work. There is no one at home to look after them. So this is a major concern. It obviously stemmed out from US because everyone's in the work zone. There's no one to look after their parents. Similarly, even in India. In India, what happens is a lot of young generation has moved out to greener shores for work. So there's no one to look after them. So we came out with a program, Elderly Care Management, which focuses on two countries as of now because we have line partners over there. We are focusing on people in Edmonton, Canada, and in LA. So the children are staying over there, but their parents are over here. So what happens is there's a 12.5 hour time difference, a Pacific time zone. So the parents literally have to wait an entire day to reach out to the children. And when the children wake up, they have a time crunch, they have to get to work. So they're not as easily available as one should be for the parents. So with this in picture, we've introduced an elderly management for parents of children who live abroad, mainly as of now in California and LA. But yes, again, like I said, if anywhere else people reach out to us, we also look into it. Our third section is the home healthcare, which I was talking about, the services that we gave the gentleman also. So we started off with a company for equipments. 7 years back, GrowCare started off as a company for equipment. So we were providing the ventilators, the pipettes, the beds, and name it, and all kind of concentrators, suction machine, whatever you need at home, every machine, from a very basic thing like a trolley table to something like a venti at home. So we started off as vendors with that, and over the years we realized that we have the means to provide something better. So we started building up our services for resourcing services, and now we are a complete in-house solution where we have our own cardiac ambulance, we have our own equipments, we have a nursing team, we have a caretaker team, we have nursing supervisors in different cities. So it's not just bureau kind of work where we assign our staff and the nurse just does what they want to. We have dedicated groups created where the nursing supervisors do audit on a weekly basis. Then we also have something called as online monitoring by doctors and intensivists. So everything is very tailor made depending on what the patient need is. So neuro rehab, pulmo rehab, patients from ICU, long standing cases, brain stroke, or someone with tracheostomy, someone who the ICU stay, we're not sure when they'll be able to come out the ICU, how much time are they going to stay, or if it's an elderly patient. So for these kind of patients, we come in the picture. We do an assessment. We tell the family that this is what you need. You need to have a doctor, because the major concern that every family has is that if something happens, who will take the call? Like just the case that I had yesterday, the patient is the last stage of liver cancer, and the family was concerned that if something goes wrong, is your nursing supervisor that skilled to take the call? So we introduced a doctor monitoring in the group. So this gives family more confidence that I'm going back home, because he knows it's terminal care, it's end of life care. I'm going back home, but it's not like I'm going to deprive my patient of the services that he needs. So we have a doctor monitoring in the group, and then that doctor corresponds to the primary physician. So it's a very easy approach. Even the doctors appreciate it, because otherwise what happens is the relatives keep nagging them for every second thing, because it's a very controlled situation when you're in a hospital, and it's very different when you come home. So for that, having these things sorted is, it's like a stress buster. Okay, your recovery will happen gradually. You are in safe hands, and you like it better. Obviously, monetarily also there's a lot difference. So what you cough out in the ICU versus care at home is a step down in terms of monetary, but not in terms of services. In terms of services, it's way better, because all of us know that in a hospital setting, we don't have one-to-one nurse equation. Okay, we always have some kind of delay. Okay, I will not say always, but yeah, we do have some kind of delay, and we are like, it's difficult, but here everything is within your room. All access to services is a call away, so it makes healing very easy, not stressful. Now we have GrowCare has its presence in India. I told you, in Delhi, in Kolkata, in Bangladesh, in Mumbai, of course, and also very soon in Bangalore. In UAE, we have an office in Dubai Health City. We have partners in Turkey, Mexico, Singapore, Thailand, California, South Korea, Malaysia. Now, helping your parents age gracefully at home, we have a product called Avni, which is our elderly care. We have this subscription module. What we give in a subscription module, this came out from need for what parents have, and this came out after a pilot study in California. Even the pricing came out after that. So a normal telephone bill over there is an $80. So imagine having these kind of services at a starting point of $99 was something which was easily available to our platform. So we started off, we initially had a 199, but then we stepped down to 99, which was a response. Everyone said it's good, it's good, it's good. But then we saw the number of people approaching. So then we decided that, we'll do a step down, we go to 99. See, families generally have a tendency that till there's not a medical event happening, they do not want to address an issue. This is the general mindset. So the preventive part of treatment, the preventive aspect, is still lagging somewhere in our communities, and that's a thought process which will take a long time. So till there's not a red flag, we don't address. This is the general scenario. So what we offer in a starter care plan is that in $99 a month, we have one physical visit given by the nurse, okay, who will see all the vitals, a complete case history is taken, and then there's unlimited service coordination. So if she needs a lab testing, if she needs a doctor visit, she has to get in touch with that nurse supervisor, and then things will be arranged for her. Many elderlies, I'm talking about elderlies in their 70s, 80s, 90s, they're not that friendly with Zepto and Zomato and stuff. So things like grocery and all, most of the time their kids are sending it through online apps, but sometimes there may be an emergency, there may be something that they need, some guest is coming over. So in that situation, they can reach out to us, and we also arrange these services for them at home. Moving on to a 199. 199 steps up in terms of services. We have one doctor visit, one nurse visit, And then we have a visit by a physiotherapist and one by either a speech therapist or a dietitian. So your 4 weeks in the month are covered. Every week someone is going to come and keep a tab on you, that is this good, is this good, is it, and then the next month the same thing continues. So this is keeping a like a round the clock check, and you'll be surprised, many elderlies do not like intrusion, so they respect the fact that, okay, you're keeping a tab on me, like the kids are keeping a tab on me through you, but not, you're not like hovering over me. You have to make them understand that this is for your good. And once when they understand and once the rapport is built, it's a different scenario. It's a wonderful feeling because you are there for them. You're filling in the void that the child should be, things that their children should do, they're not able to do. You are there. Like it just like she just, I have one patient who just the whole thing of not having her daughter, when she has a problem in her urine is discolored and she's wondering what to do. So we have a doctor visit for her, we do lab testing for her, we set the ball rolling, and then she's feeling better. She was having a lot of issue with stiffness and body pain, so we had a physio assessment done which showed the need that, okay, she has stiffness, she needs to be doing physio regularly. So once she saw that, yeah, this is making my life better, because at 90 she's doing all her chores, she mops her house, she sweeps her house, she does the cooking for herself. And when she saw that, yes, this is making difference, she was more welcoming to us. Her approach was also that, okay, this is for my good. So she likes it now. And the ultimate care plan, what we have is supposing, apart from, so all the services that are there in 199 are there in 499. Apart from that, as an add-on is that we have a caretaker stationed at your home for the office hours. This is especially where you are scared of a fall, or you've had a past history of a fall, or if your parent has a tendency to have an electrolyte imbalance and you just don't want a fall to happen. So you have a dedicated caretaker stationed at your home for 10 hours. So, elderly management is when all the hospitals, they have access to us. So, supposing there's a need for a nephro consult, we see the nearest hospital available and we arrange the visit. If there's a need for an intensivist, if there's a diabetologist or intensive diabetologist, or any concern that they have, because they don't know what to do, so they come to us and we guide them. Home healthcare provider. So what are the different things that we cover in home healthcare provider? We have ICU at home, we have physiotherapy at home, we have all kinds of equipment at home, we have nursing care, onco care, palliative care, end of life care, and the American term for it is comfort care. It's a different program altogether. So patients where we know are stages of terminal cancer, who can be given only symptomatic relief, or who can be given, it's just palliative care that can be done for them. We also help such families with palliative care at home. We have nursing attendants at home. We have dialysis at home. We have teleconsultations, elderly care, diagnostics at home, yoga at home, all kinds of lab testing, including COVID testing, ambulance, air and ground both. We have our own in-house full-fledged cardiac ambulance. So if you need something, we can just arrange that for you. One thing I forgot to touch base on the elderly care was that we also, uh, in each of this package, if there's a medical emergency, God forbid, of course, and if the patient needs to be rushed to a hospital, we have our own cardiac ambulance which rushes the patient to the hospital. So if it's an odd timing, because emergency is not severe timing, if it's an odd timing, we do not have to waste time in coordination. We have our own, we get the call from the patient and or his next of NOK, the next of kin, and we get going. So with GrowCare, we are looking at growing together, achieving rehab for more number of people at home, achieving rehab in a systematic manner, be it neuro, be it palmo, be it onco, and rehabilitation is ongoing. um, I would say it's a team approach. We have a lot of people involved in it. There's the family, there's the nursing staff, there's a therapist, physiotherapist, speech therapist, respiratory therapist. In some cases like this, there's also a cognitive analysis, a neuropsychological person. So we have so many people involved, having them all together on board and ultimately doing what is best for the patient. So at GrowCare, we're looking at getting that team approach and doing what is best for the patient interest. With that, I would like to say a thank you. And thank you, Deposhmita. I think I've done my part of talking. Over to you.
Ahana, please share the video where the
Yeah.
face is morphed, please, because it
Yes,
this
yes,
covers
yes.
another
Yeah.
case completely.
I will share that with you. So this is the GrowCare website where we put up the doctors that are in touch with us. We put up the various hospitals that are in partnership with us, and we also have some kind of case studies. There's a lot of informative video going on these websites. This case also I had presented on the website. Let's see it. That's a cardiac ambulance taking the patient from the hospital, settling the patient at home. His son is in Canada. That's the physio. He's able to sit in a neuro wheelchair, engage in conversation. He's sitting in his family. You see the diary and the pen. He's writing down things. There's one more thing that I would like to show you all is this. I have not touched base on a lot of language activities that we do, but this is the way we have made it for him. We have tasks, we've different tasks are done, and morning evening slot is done. So this is supposed to be done with the nurse, with the daughter, with the son. Okay, left side, because of the neglect that is there. So tracking is there. We have stickers on that side. We ask him to track the sticker, identify, track it. Then there is more attention task given to him where the charts are given where he has to strike off a number or see a color, strike it off. The different sorting activities are given, matching game, reading and recognition, time identification. Because what time, a very simple way of time identification is that now what we have to do with the caretaker asking that now this is time for what. So it's also a routine, and also the morning evening time, also literally seeing the time. So we have a clock in the room and you know what time of the day it is. Then simple step by step task sequencing, color and object identification, visual tracking with light. Now, these tasks were decided in adjunct with a neurocognitive therapist, because the cognition is compromised. So, this task were designed keeping that in mind. Obviously, we took help of set speech also. So, everything was incorporated together to do what is best for the patient. A very interesting report from the um, session, this one. So we did a neuropsychological evaluation at some point because the family was demotivated when we tell them that it is the patient's limitation. You know, as therapists we know it, but putting it across to them may not be easy. That this is the insult, this is the repercussion it's going to have. So when we did an evaluation by a second person, detailed evaluation was done. Okay, and a very interesting finding, which the way we've done it back in our school days, back in our college days, case study, was the impact of the site of lesion with the patient condition. So what was seen was that there's the neuropsychological evaluation findings closely aligned with the patient's diagnosis of non-traumatic intracranial hemorrhage involving the right corona radiata thalamic capsular region with intraventricular extension and a midline shift. So the damage to the right corona radiata and thalamus likely underpins the hemispatial neglect observed in the patient, particularly the inability to perceive stimulate on the left side and tendency to ignore the left side during visual spatial tasks. So we know how we're supposed to stack it up. Focus more on the right side. The thalamus, a critical hub for sensory and cognitive processing, may also contribute to impairment in set shifting, selective attention, sustained attention. Because this is where you give a task to the patient and he doesn't want to do it. He simply doesn't want to do it. And why? Because something at the higher level is stopping him from doing it. So the involvement of the capsular region may explain the motor-related difficulties such as limited engagement, slow task performance, deficits in short-term memory alongside preserved long-term memory, suggest of selective damage to networks responsible for encoding and retaining recent information, while biographical and deeply ingrained memories remain intact. The patient's emotional disengagement and lack of intrinsic motivation could reflect disruption in thalamocortical and limbic circuit. Very, very, very important. Very important for counseling because there are some days where he doesn't want to do any activity with you, and you cannot force him to do that. So we have to understand that when we have a particular side of, we as therapists have to understand that what are the limitations of this side of Asian. I have covered most of it.
It was very comprehensive. Like, I would now invite the audience to, if they have anything to ask you for more clarifications, whether it's the case or GrowCare. I think you covered both beautifully, and it gives all of us a very good idea about what kind of help is required, whether it is for our family, whether it is for the kind of patients that we see, and that you can be approached for these kind of services. These are available. So it is open to the audience if you want to ask Hannah something, if you want to get something clarified, if you want to share any of your anecdotes, it is up to you. Otherwise, on your part, it was beautiful that you covered everything, including the last neuropsychological evaluation that you just showed. It was really nice, Hannah. So, Anna, do you want to share the video of the patient? I can
Yeah.
pause the recording for a while.
Yeah. Not doing to achieve.
Yes. No, so and also what with both your case presentation today as well as GrowCare, what you managed to show us that the medical intervention may continue in some cases, like
Yes,
with
yes.
this also what you were trying to show. Go on, please.
So very important over here is medical intervention. Now, in this situation, it was a blessing for us that his own nephew he's a leading endocrinologist. But the
Okay.
initial phases, there was so much of BP going down, there was so much of fluctuations, and without any apparent trigger. So we very important for us to have access to medical team, you know, so that you intervene in time. It's not like things worsen and then you take a call.
Absolutely.
So having
Absolutely.
access to all these people, I would like to share one more thing.
Yeah, yeah, sure.
So this is the group that we have for the patient. Okay,
Okay.
like you see the secretions right now. This is what is
It is
happening.
not sharing, Hannah, it's not
Okay,
sharing
it's
yet.
not sharing it.
Yet. Yeah. Yeah.
So this is the way we create a group for the patient. Okay, where there is a regular update given by the nursing staff. Okay, we have the all the regular updates, the nursing care, the exercises, the TT part of it, the tracheostomy part of it. Then stimulation is done. NPSY is the chart that we've made for the patient, the various activities that I showed you for language, and that's done. Now again, we're doing the first day patient was taken out without O2 support. So we are still in that zone of getting him without O2 support. Now because he went out, there was dust, there was a slight increase in secretions again. So this is an ongoing process. We had a tracheostomy tube replacement done for the patient that was documented over here. So we are closely documenting what we are doing.
Correct. Absolutely. Absolutely. And the close partnership that you are going on with the swallowing, the strengthening, as well as the language exercises, which is ongoing. I personally wanted to commend you on the spreadsheet that you made, because I saw the pages, for the son, the daughter, and the caregiver. You have
See, it's not just a one person. See, it's very important to incorporate everyone because you also have to train them. So incorporating the
absolutely
family, the nurse, and in most of these cases, it is the caretaker that we have to rely on because ultimately, see, the daughters don't stay home, the son doesn't stay here. So we have to train them. We cannot be having somewhere you have to accept that fact that financially you cannot be having therapy every day also for them.
yep,
So though you want
absolutely.
to keep it intensive for them, so somewhere a trade-off has to be done. So this is the best thing we could devise for them. So we have
It is
spreadsheets for.
the best thing because it is you, the SLP, who is sitting there. So apart from the physio and the exercise, you have such beautiful language and the swallow training program which is going on. Because otherwise, it would just be the physical, and this language things would not be happening. Now, even I have a subscription to Set Speech, and I know the kind of activities Tasneem has made
Yes.
available, and it is so useful for the adults. In finding in the what is wrong thing.
So the
It is.
face value, the odd man out,
Yes,
the face value of set speech is very, I think it's very easy to use that. And the flow, for me, time is
correct,
a very important tool because they have a short span of time. If I'm shuffling and arranging something, I'm losing out on my valuable time. So within the
correct.
limited time that I have with them to do therapy with them with set speech, I think it's a very good tool that I personally like. And you vary the task. The same thing can be used for naming. She's made it very well, no doubt, but you have so much of tool at your access, so you just
Absolutely,
vary it and you just go
absolutely.
on.
So
I'm
it
glad to
is like
see you.
It is like your armory is there in one
Yeah,
tablet,
exactly,
and
exactly.
as against children, it is not the screen which is the barrier, because with children we don't want them to get the screen, whereas with adults it is like so beautifully accessible and available and things. Go on, you were so happy to see. Go on, tell me.
I'm happy to see people join in, and I would love to hear from them. If they have any kind of feedback for me, maybe some of you might ask the question that why have we not done thermal stimulation for this patient? Why have not, sorry, not done electrical stimulation for this patient? Remember the first back history that I told you, the cardiac history. Back in 2022, he has major blocks. He has stenosis. He's a known case of ischemic heart disease. So with that in picture, the family was the doctor's team involved was very keen
Skeptical.
on not having electrical stimulation.
Yes.
They were, because of him being unstable in terms of his BP. There were two episodes. One, unfortunately, there was one episode where we did an orator trial, and very soon after that, he went. It was not desaturation; it was a change in the heart rate, then followed by a change in his BP. So we can't say that orator trial was the event, but somewhere it leaves a mark on the family. So
Correct.
then they are skeptic for the next orator trial. So then again, we have to slow down. And with electrical stimulation, we were skeptic, so we just had to have the right balance of exercises and thermal stimulation. It will take time, but we are sure we'll be able to get there one day at least. We will consistently. We will get there.
Yes. So Hannah, thank you so much. I don't see anything. Okay, there is one by Prasanna Hegde. He says, "Great presentation. What kind of tracheostomy tube is it?" Listen to me. Have you got any instrumental evaluation? You can read it simultaneously
Yeah,
in the
yeah.
chat. There are many questions. What is the reason for the voice problem? Is there a vocal cord palsy? Why is the track still there? Why would you want to give electrical stimulation? Go on.
Okay, so hello, sir. Glad to hear from you. So, presentation, what kind of tracheostomy tube is there? There was an inflated cuff. I have written down notes on downsizing also. Have you got any instrumental evaluation done? Yes, I've got fees done twice. What was the reason for voice problem? Is there any vocal cord palsy? There is no vocal cord palsy, but he's not able to produce voice consistently. Why is the track still there? He's not able to manage his secretions and his saliva. There are times when you put him on the orator trial and he's unable to swallow and there's a built up. So he's unable to, we cannot go in for decannulation trial. We just had recently, last week, we had an evaluation by the ENT, and he's still not reached a level where the secretions are not there. So if we put him on a deflated cuff, if we put him on a deflated cuff, we put an orator on C2 for a long time, there is this build up of secretion that is happening. And that is the reason we cannot get him off the track. Why would you want to give electrical stimulation? Electrical stimulation is known to be effective for improving the swallowing efficiency. There are days where he swallows, there are days where he doesn't swallow. So to have consistency, we've seen results with electrical stimulation. We would want to try, but we are not doing it. I hope that
What does
answers it.
what does the fee say?
So the first fees evaluation that we had was it was done in the hospital before his discharge. So that time he had pooling. That time his swallow was affected. After that, there was again pooling present on the fee. Let me just see if I have the fees. So the fees is showing pooling and um, intermittent aspiration. There's a lot of pooling of secretion present. I've missed the fees evaluation. I will try to track it down. I've had so much of documents that I've actually missed that part. But the fee says that he um is the tracheostomy tube fenestrated one? Did you say it was with a cuff? It's with a cuff. It's not a fenestrated one. It's the one with a cuff.
Hi, Hannah.
Hello, sir.
Can you hear me?
Yes, sir. I can hear you.
Hi, hello. Fantastic to hear you present, and of course, the things about we getting into industry and collaborating with them. It's a fantastic thing. But we have some of the questions, like probably I'm not really sure if the speed with which rehabilitation was supposed to be done, is it because of the logistic reason, decision makers are outside and they're not giving you enough clearance. See, what we would do is we would focus aggressively on taking out the tracheostomy tube. Um, we said that there's probably not no vocal cord palsy, but breathy voices there. It would say that it could be because of inefficiency because of the presence of tracheostomy tube. Could you trial on food with the tracheostomy closed? Did you try
I
any food
yes,
food
yes, yes.
with
So
tracheostomy
one
closed?
second. Can you see this? So this
Yeah,
was the evaluation on 8th March by an ENT.
30 minutes with no increase in secretions. Okay.
But this scenario doesn't stay throughout. We have tried food. That was one episode that we tried, and then again there was a lot of activities which set us back. So even now, it's more of a peg feed that is happening. He's not able to swallow his salivas. He's not able to swallow that secretion. There's a secretion built up. You can see it on the
Is,
image also.
is
This
it
is
the
this morning.
is the secretion is the
This is this
secretion
one.
only the problem?
Uh, he does go into desat then, so we have to suction him out, and then there's a
Okay.
little bit of desaturation that happens. He's not comfortable, sir.
Okay.
He's not able to manage
What?
it.
Yeah. So he's able to comprehend all the instructions.
Yes, yes. He's able to comprehend all instructions, and the language
Can,
part is completely intact.
can he take out the phlegm through mouth?
Yes. So I showed you a picture where he is able to cough out, but there's some blood stains sputum. So
Yeah, I
he's able
think
to cough
more
out also.
facilitation on that. If you
Sorry,
can
sir.
reduce the suctioning, if you can reduce the suctioning,
We
I
we
know that
are
whenever there
reducing
are
it. Yes, sir. We are reducing it. We are asking him to cough it out as often as he can. But we've generally seen a parallel between an orator trial and a buildup of secretion. Generally, we've observed that. So when we are having the patient on orator trial, there's a buildup of secretion where we give him repeated commands to swallow, but he's not swallowing it. Then ultimately, it's all pooling up in his mouth, and then that has to be suctioned out.
there is a mouth suctioning as well, oral suctioning
Uh,
as well.
it is oral because it's built up over here. It's oral. It's oral mostly. There's built up in the mouth, so
Yeah, well, a
tracheal
lot
and
of
oral. So there are
dependency.
different days. So there are different days that the last time I was there in person and we put him on a orator trial, and there was a lot of built up in the mouth. But every day is a different day with him. Some days it's not there. Some days he's able to swallow it, but then the consistency of that good day window is very less. So, is there
At
anything you
this
would like to
time,
advise me
I mean,
to
when
do?
the,
Anything that from your
so
end
I
which
think
you think?
I would have liked it, the parallel neuropsychological thing that is happening. Aggressive physio, more, work more on cough training, because what I think is only cough is stopping you, as in not having enough strength to take it out. Secretion is the only reason why you're not able to take out the tracheostomy tube. I mean, that is a burden. That is a healthcare
That
burden
is.
overall.
So the sensory
Now,
arc is affected,
if
sir. When go on, I'll tell you later.
no, those are all the aspects that isolated things which probably only increases the problem. But major problem is about whether he can cough and take it out, whether there is sensory problems, whether there is oral cavity problems. So if you make him take out the secretions by coughing out, suctions are not required. Tracheostomy comes out. Now desaturation is because probably is getting narrowed down. And if you can look at changing the tracheostomy tube to a fenestrated one, or something which can be easily used for taking out the secretions from oral cavity, then it becomes easier.
So
So
in
there are
your opinion,
fenestrated
a fenestrated tube
double
will
lumen
help
cannula.
him? Yeah, I've had a patient. I just with the fenestrated. In your opinion, a fenestrated tube will help him cough out better, facilitate better coughing out of secretion.
Yes, yes, definitely.
Yes.
There's
Okay.
a double lumen cannula, so you can put back the inner. non-fenestrated cannula, if you think that he's not able to sleep at night, he's vigorously coughing every 5 minutes once he's getting, he's requiring suctioning. But during the day, you can put him on deflation and
We're doing that, sir.
fenestrated tube, so that
So what we are having
you
is
can
we
work
are
on voice
yes,
as
sir.
well.
Yes, we are working on that.
You can work on voice as well. If you can work better on voice, these all becomes easier. Now, I would also think that subglottic pressure built up is less. That's why efficiency is affected. Now, if he's having multiple swallows but still it's not getting cleared, either we have not understood the physiology, or we don't have information about the physiology by instrumental evaluation, and we are targeting as a generic treatment protocol. You're not really targeting specific things that are affected. When you said it is oropharyngeal dysphagia. Oropharyngeal dysphagia is a vague term for us. So for an SLP, probably we would like to look at, okay, whether there is hyolaryngeal excursion is there or not. Now, if
Apparently, excursion
hyolaryngeal
is there.
excursion is not there, if it is there, then we look at having only sensory level of stimulation for electrical stimulation, not really the contraction level. I think if you can revisit the instrumental evaluation and see what is it that the major problem that is controlling everything. Is it the vocal fold not closing when you want it? Is it because of the tracheostomy itself? Let's say you have a tracheostomy changing procedure that is there probably in the near future. Take out the tracheostomy tube and see if everything settles down. Give him 4 hours of time and see if he is able to manage. Sometimes tracheostomy itself becomes a problem. It may be a dependency. The patient may not be wanting to go out of it. He's become too comfortable with suctioning, and all those care, it makes it comfortable. So little more effort becomes too much of a burden for them, and they may not be understanding that they have to put an effort, especially right hemisphere damage. uh, you know they may not understand that it is them who have to decide whether they have to improve or not. So that perception of those aspects will be difficult. um, I think it's a complex case, definitely, and a lot of people will be involved. And I would also request, if at all, you can talk to medical fraternity to give as much as freedom as possible to try out different things. I know it's a vulnerable patient. Unless you take adventurous step, you will not be able to progress. It's a balance that you do. You know that risk, right? You knowingly you go forward to decannulate and see if it's okay. Now, in our hospital, we keep doing such things that now, if you're not able to progress to step two, we skip that step two. We go to step three.
So I'm taking
So
on
six
notes from
months,
you, sir. I have one question,
yeah,
sir. I
yeah.
know there is hyolaryngeal excursion for water at 20 seconds. According to me, I feel that the sensory arc is affected. So, with this picture, like you said, specifically what part, what advice would you give me to better facilitate his swallow?
See, if it is sensory arc alone affected, so it would have major problem for liquids, especially water, something which does not have sensation, right? If you can control the bolus flow. Now, if the water is only the problem, then semi-solids or solids shouldn't have, soft solids shouldn't have been the problem.
But we see
Having
aspiration.
more and more, you see aspiration,
We
then
see
it is just
aspiration.
not the, yeah, it's just not the sensory arc. It would be the weakness, weakness in the pharyngeal squeeze. It could be high laryngeal excursion not being enough at the time when the food goes there, because you need to have a squeeze. If you can balance between the both, between water and the soft diet, or something which is thicker in consistency, it flows well, and it can be cleared out easily, which is more cohesive in nature, then probably it would clear out the secretions as well, because there are not much activities of swallowing. Secretions also build up. Secretion doesn't have any taste nor temperature. There is no trigger for us to swallow unless it is getting full, and especially with patients who are on tracheostomy tube for that long, the sensation is already gone and the pressure built up is already gone. There is no subglottic pressure building up. So more and more, corking trials of, even during the night, because night is the major challenge. So even if you can achieve safety of swallow during the day, night also is a problem, because microaspiration happens that time as well. So I think what
So,
the only thing I would ask is that speed up. in terms of trying more and more. Whatever is happening is great, but only thing is that even in such kind of patients, you may not be able to pinpoint on certain deficits because there may be overlaying deficits as well. There are multiple factors leading to swallowing problems. You by the time you start to understand that okay, high laryngeal excursion is a problem, but you may have other issues as well contributing to it. So you cannot single out anything. Initially start with definitely how you did generic kind of treatment, and as you go ahead, based on the improvement, you need to figure out what is the exact thing I need to point out. So regular instrumental evaluation, if you can do, find one safe consistency, continue to give it 100% as much, 100%, target 100%. Even if you don't want to change the different consistencies, don't go up towards soft diets or come towards liquid. Even if you have to use at least a month, single consistency, you should be able to figure out whether saliva can be, uh, you know, um, cleared during the swallowing event or not.
And what if he keeps holding that bolus in his mouth?
You can have a pacing techniques, you can have queuing, because anyways
Okay.
there will be a person giving feed. It is easier to give something which is chewable, right? So when the chewing happens, there is a sensation, there is a proprioception that happens, rather than fully mixy paste and give it for gulping. It may not give you that much response. You might have pungent tasting things, or anything that probably alerts him, which would ask him to participate more rather than just saying that okay, this is safe, let me give it, or even to just to have an activity of chewing, it should be good.
Thank you so much, sir. Because even we would want to proceed further with him, but when we do not see things happening with the secretions getting built up, so then we do not proceed with that consistency of food consistency.
Yeah.
So that is
So my
a step back. It's a block for us, because he doesn't
Mm,
swallow. There's no trigger of swallow that is happening. So then we are forced to stop, abandon it at that point.
that's right. Yeah, it's a challenge. Any time when cognition is affected, especially RHDs, clinically they shouldn't have swallowing difficulty, but they show more difficulties with higher degree without having an explanation. Why would somebody build up a saliva in the oral cavity? So that's something which is, very interesting to work on. It's a challenging aspect, and it will definitely take a lot of energy from you. I mean, the only thing that you can look at is have a team which can do what you do at a regular interval. If you have done in the morning, somebody does in the afternoon as well.
Yes, yes,
Multiple times, if it can be done, it gets even faster.
yes, sir.
Thank you
Thank
very
you, sir.
much.
Thank you, sir, for that feedback. It was very important for me because I would like to move forward with him. I'm glad to get this kind of feedback. Thank you again, Devashmita. Means a lot to me, especially coming from Prasanna, sir. So,
That was indeed insightful, and I hope that is helpful to you, Hannah.
yes,
So it was worth, with putting up this case and talking about GrowCare also. So, Hannah, this is a very small token of appreciation
thank you
from
so much.
Insightful. Hopefully you can reach out to a greater population that you're looking at healthcare as such, and also that you are personally looking into the entire swallowing dysphagia therapy as well. So thank you for doing this with us. Thank you for doing it on a Sunday morning, and thank you to the entire audience. Thank you, Prasanna, for giving her the feedback. Thank you to the audience for being here on a Sunday. I hope you had fun, Hannah, doing
Yes,
this.
I thoroughly enjoyed it. I'm looking forward to more case presentations, definitely now, because it's
Please.
a learning process. I would like to thank you again, Devoshmita, and I would like to thank my team, especially Saranas and Siddesh, who've been with me as a part of speech therapy, being as consistent as it needs. And I'm just going to try to step up things a little more, as Sir said. And hopefully, I think we should have a next review on this case itself, where we can show some progress in the
Sure.
near future.
You have to set up the date. I'm your host. That's
Yes,
all.
yes, yes. Thank you.
Okay. See you, everyone. Have a good
Thank
Sunday
you.
afternoon and the
Thank you.
weekend ahead. Bye bye. Thank you so
Thank you,
much.
everyone. Bye
Yeah.
bye. Good day,
Bye. Bye
everyone.
bye. You too. Bye.